Hey everyone, I just got a notification that my speaker's not working properly. Are you guys able to hear me?
Yes.
Yeah, we can hear you.
Okay, awesome. I had a moment of panic. It's like we've got so much to cover. Um, so some of you guys are already doing it, but please sign into the chat with your full name and cohort, just so I can take attendance that way. And we'll get started here in just a second. I hope you guys brought some coffee or a snack. We'll take a little mini break about midway through this, explore more, and then we'll keep going. But we've got a lot of content to cover. By no means are you obligated to stay for the entire session. It's a long session. You can certainly watch the recording later if this is too long for you. But typically for exam 3, I like to do lots of preparation. All right, for those of you that are here, appreciate you. I appreciate you more if you turn on your cameras so I can see your faces, so I don't feel like I'm speaking out into the void. So you can at least fake laugh at my lame jokes. But let me share my screen and we will get going fairly soon. All right. Traditional login using a QR code via GCU. If you guys can do this login, this is the official login. So my chat is just for my purposes. This goes to the university. So please make sure that you use the QR code and do the official login. Give you guys a little bit of time to get that done. Okay. So here's the deal, guys. We have a lot of slides to get through, to discuss, to chat about, to talk about. I'm covering a lot of drugs in preparation for this exam, but I did do a count of my slides, and there's over 100 slides in preparation for this Explore More. So I'm hoping that you guys can hang with me for a while. Last semester I had to do this one. I think I started at like 8 o'clock at night, so we were up late. So at least it's a little earlier in the day. Maybe you're a little bit more spry, a little bit more, with it. But I'm sure you guys are tired. It's probably been a long week. But without further ado, we're going to get into it. So my first question to you are, what are signs and symptoms of a bacterial infection?
Fever.
And irritability.
Yeah, so irritability, I heard fever. I missed the first one that you said, Daisy, that you unmuted and said.
Oh, I said irritability. Yes.
Yes, irritability. Okay. And thinking about some of our cardinal signs and symptoms of infection. So we have fever, malaise or fatigue, right? Body aches in our patient. And then what lab values might we see in our patient who has a bacterial infection?
High
WBC.
and blood cultures.
Yeah, positive blood cultures and white blood cell count is typically elevated, right? So my next question to you is, what signs and symptoms would indicate that an antibiotic is effective?
Low WBC count.
Yeah, so we'd see that white blood cell count trending down, right? We would see that signs and symptoms of infection like fever, inflammation, and fatigue would start to alleviate in our patients, right? And so you guys, we talked about this in class earlier this week, but you guys probably have all had some type of bacterial infection at some point in your life. Now, you may have had cultures, you may have not, right? You've had strep throat, you've had a culture, right? We do a throat culture, check them usually around the tonsils. If our patient has tonsils, we do a little bit of scraping with the Q-tip, right? And we send send in it usually in office for testing, and get the results within about 15 minutes, right? We can do this with flu. We can do it now with COVID. So there's a lot of information that we can gather related to viral and bacterial infections. Sometimes we do blood cultures, wound cultures, urine cultures. Cultures take a little bit more time than some of these more rapid tests usually. So like a blood culture or a urine culture can sometimes take a day or two to get the results back. Sometimes with blood cultures, maybe even 3 days, depending on the facility and how far they have to send it out. But what I want you guys to think about with these questions is, what does a patient look like? What assessment criteria would indicate to me that my patient has an infection and it's a bacterial infection? And what criteria, and how can I look at that and evaluate to determine if my patient is getting better after administering an antibiotic, right? So we're thinking about our goals and goal-oriented care with our patients. What are some important factors to remember when taking blood cultures?
You need about 15 mils and you need to do one from 2 different sites. So usually one on each arm.
Yeah, 2 different sites for blood cultures. And then the big one is, when do we do this lab draw?
Before antibiotics.
Before antibiotics. If my patient has an IV, can I use their IV?
No.
Right? We actually have to do venipuncture on our patient, okay? Now, there are some exceptions to this, but we don't cover them in this class. So if a patient has a port or a PICC line, central line, sometimes we can draw from those as one of our potential sites, right? But typically we do not use an IV. We do not use intravenous access to do blood cultures. We do venipuncture, and that's what you guys need to know. So you may have seen something different if you work in an acute care setting. Maybe you worked as a phlebotomist, something like that. But for the purposes of this class, we don't use an IV, right? For for drawing blood cultures, we use 2 different locations, right? And we draw before we start antibiotics on our patient. Right? So of course we're going to clean the skin before we puncture the skin. Not on an IV line. 2 culture specimens from 2 different sites, 10 to 15 mLs of blood, send specimen to lab immediately, right? What is the difference between a broad spectrum and narrow spectrum anti-infective medication?
Broad spectrum treats more things, and narrow is like more selective.
It's more selective, more focused, right? And both can be strong. Typically with our more narrow spectrum antibiotics, we'll see that they're stronger, right? It is going to be important for you guys in preparation for this exam to tie the types of antibiotics or anti-infectives, antivirals, whatever it is we're talking about, to the conditions that they treat best, and also to the super infections that can occur associated with those medications. Different types of antibacterials that we've talked about. Some inhibit bacterial cell wall synthesis, some alter membrane permeability, some inhibit protein synthesis. They act in a number of different ways, right? What are the potential consequences of antibiotic misuse or overuse?
Antibiotic resistance.
Sorry, both at the same time. Couldn't hear you. Now you're scared.
Tolerance.
GI distress?
Gastrointestinal distress, yeah. And actually that's a potential side effect of most of our antibiotics, right? Is gastrointestinal distress. So some of that can be mitigated with, say we teach our patient to take it with food. There are a few antibiotics that certain types of foods don't play well with, right? We'll talk about some of those tonight. But when we think about misuse or overuse, yeah, if we use antibiotics for too long, we can build up a resistance. So I want you guys to think of the word resistance when we think about antibiotic use or misuse, right? So if we don't, for example, take our antibiotics, the full prescription, right? Then we can put ourselves in a position where we're creating bacterial resistance to the medication. right? We talked about this a little bit in class, went into a little bit more detail. If we have overuse of antibiotics, I think somebody said tolerance, right? It's just not going to be as effective over that period of time, right? We're just using too many antibiotics, or we have a lot of antibiotics on board. It's going to take more and more antibiotics to elicit the desired therapeutic effect. So similar consequences with a lot of our medications, right? So we can have some resistance with antibacterials. There's inherent resistance and acquired resistance. With healthcare acquired infections like MRSA, VRE, VRSA, these can all potentially be very difficult to kill. And these are highly resistant strains of bacterial infections that have basically been generated by the most potent bacteria and by the misuse of antibiotics, right? So now we have these strains of infection that your standard broad spectrum antibiotic, it can't hack it when it comes to some of these more severe strains of medication. So we have to use stronger antibiotics. For using stronger antibiotics, our patients at greater risk for the side effects associated with those antibiotics, right? And at greater risk for toxicity. So antibiotic misuse increases antibiotic resistance. Antibiotics are often taken unnecessarily. So if you guys ever go work in an urgent care, you are going to hear people constantly asking for antibiotics when they have viral infections. We talked about this in class. A viral infection, what benefit does an antibiotic have for a viral infection?
None.
None, right? Viruses tend to be much smaller microscopically than bacteria and much harder to kill, right? So a lot of times with viruses, what do your providers tell you? What directions do they give you in terms of how to combat viruses?
Drink fluids and rest.
Right. We're going to treat symptoms, right? So if you get the common cold, you take cold medicine, but there's no cure for it, right? If you get the flu, sometimes within the right window of time, you can take an antiviral. Same with COVID, right? Now we have antivirals available. But a lot of times you're just told to kind of wait it out, right? How many of you guys have gone to the doctor and maybe you've had like a bronchitis, right? And your doctor says, hey, let's try rest, fluids, and treating some of the signs and symptoms. But if it doesn't get better in a few days, we'll prescribe you an antibiotic, right? Sometimes that happens because we may start out with a viral infection, but it weakens our immune system and allows bacteria to take over. So sometimes you'll start out with a viral infection and develop a bacterial infection, but we like to try to hold off on introducing antibiotics for as long as possible, right? So we don't take antibiotics when no bacterial infection is present, and we take antibiotics correctly. So we have to follow a specific dosing schedule with antibiotics. If we skip doses, miss doses, this can also potentiate the risk for resistance building up. What are signs and symptoms of an adverse reaction to antibiotics or antibacterials?
Allergic reaction, you mean?
An adverse reaction could be an allergic reaction. Yeah.
Rashes?
Rash is usually one of the first signs. Typically, we associate rash with our xylins, right? So penicillin, amoxicillin, those types of medications. But a rash can be a sign of a sensitivity or a hypersensitivity to the medication, right? So if a patient presents with a rash after the first dose, it's possible by the second dose, third dose, that they could develop an anaphylactic reaction, right? So we're teaching patients, if you develop a rash, you need to call the doctor. Most important adverse reaction, though, is airway constriction, right? Anaphylaxis. We have a really severe allergic reaction. That allergic reactions with antibiotics, unfortunately, are very common. Most common allergy in the world is penicillin, right? And so I'm sure you know somebody, and I'm sure there are people on this Zoom right now who are allergic to penicillin, right? But that anaphylaxis is a really dangerous adverse reaction, right? Now, there are some adverse reactions that are specific to the medications that we're talking about. Almost every antibiotic that we discuss carries a risk for super infections, right? And those are a potential adverse reaction to the medication. So things like C. difficile, stomatitis, vaginitis, right? Those are all potential adverse reactions to the medication, would indicate a serious problem with the patient, right? Additionally, we think about things like ototoxicity. There's a few of our antibacterials that we're discussing this time that can cause ototoxicity. So actual hearing impairment that can be permanent in our patients. And then, of course, we're thinking about our two favorite types of toxicity, right? Hepatotoxicity and nephrotoxicity, right? So we're watching those lab values of AST, ALT, ALP, and our BUN and creatinine levels on our patient. So we're monitoring liver and kidney function because a lot of our anti-infectives are hard on those organs, okay? It is going to be important that you know what the typical adverse reactions are for each anti-infective that we're discussing. So some of them may be more prone to vaginitis or stomatitis or anal itching or things like that. And you want to know which drugs match, okay? So we talked about some of these allergic reactions, superinfection. The usual sites for superinfection are mouth, skin, and respiratory tract, can occur in the genitourinary tract or the intestines, right? And then our organ toxicity, ear, liver, and kidney, okay? We talked about the differences already between narrow spectrum and broad spectrum antibiotics. In terms of like gram negative, gram positive, all of those things, I don't want you guys to focus on that too much. Just focus on, you know, these cover a lot of things versus covering a few things. So, penicillin, what type of drug is it? What is its classification?
Broad spectrum antibiotic.
And what are the indications for use for penicillin? Some of the most common.
Ear infection.
Yeah, otitis media. You'll see that on your exam, right? Don't get your terminology confused. That's definitely one. There's a few others, strep throat, but this is for like your pretty common run-of-the-mill infections, right? What assessment criteria do we need to include prior to administration of this medication?
Make sure they're not allergic to it.
Yeah, this is one of the most common allergies in the world. It's actually the most prominent allergy in the world. And so if that's the case, we have to assess, are you allergic to penicillin, right? How many times have you guys been asked that when you've gone to the doctor? Let's say you roll into an urgent care, you just get in a quick checkup because you're not feeling well and they say, are you allergic to penicillin? They want to know, right? In fact, a lot of times they'll ask you, you know, what your allergies are at the beginning of the visit. And then they'll ask again if they're going to prescribe an antibiotic, right? Because they want to know. So what do we need to monitor while taking this drug?
For signs of anaphylaxis?
Yeah, definitely, right? So initially, a lot of times when patients take this drug, they'll develop a rash first. Sometimes patients will just jump straight into anaphylaxis, but we're going to teach our patient about that potential rash, or if we're giving it through the IV, that carries a greater risk for reaction, because when we give medications through the IV, how much of the medication is absorbed into the bloodstream?
100%.
100%. So you're most likely to have a reaction pretty quickly when you're giving medications intravenously. So if that's the case, we want to stay with our patient if it's the first time they're having a medication for the first few minutes of that administration. Usually when we're giving medications through an IV, reaction time is pretty quick, right? If patients are going to develop a reaction. How do we know if this drug is working?
Improvement of symptoms.
Yeah, typically when we think about penicillins, these are out and about in the community type infections, although I have given this medication in the hospital setting through the IV. But we're giving this medication and we're teaching patients, hey, if you don't feel better in 2 to 3 days, you need to come back, right? Because if you're taking this medication consistently and it's not working, then we may need a stronger antibiotic, right? We're creating a risk for sepsis. So usually, you know, you get your strep throat, you take your penicillin, or a medication that's in the same kind of family, and within about 24 hours, you start to feel better. In fact, most of the time with those types of conditions, they'll let you go back to work or school 24 to 48 hours after you start the antibiotics, right? What are some complications associated with penicillin? We already talked about some of them, right? The big one, anaphylaxis, allergic reaction. Okay, so this is just some review of different types of penicillin. There's basic, broad spectrum. There's some stronger penicillins. There's extended spectrum. These typically, they can work two ways. So penicillin is unique. There's some different formulations of penicillin. So it can be bactericidal or bacteriostatic. What's the difference between bactericidal and bacteriostatic?
Bactericidal kills it quickly, and then bacteriostatic inhibits the growth of the bacteria.
Yeah, it just breaks up cell division and then gives your white blood cells chance to, take over the fight, right? So yeah, two different types. Penicillin can do both, depending on dose and potency of the medication, right? Our penicillin, our broad spectrum penicillin, amoxicillin is one of the drugs that we talked about. This is used to treat otitis media, tonsillitis, sinusitis. We also use antibiotics for the treatment of gastrics and duodenal ulcers. So that's important to remember that antibiotics are used for a lot of gastrointestinal issues. And so this will come up again when we talk about gastrointestinal medications in the next unit, but this is important to remember. We'll also use amoxicillin for skin, respiratory, and urinary tract infections, right? Like strep throat is an upper respiratory tract infection. All right, I talked about these a little bit. I'm going to post these, I promise. But you can also find them within your PowerPoints. You can create your own, you can make blank ones and fill them in. You can make a game out of it in your study groups, however you want to do it. But these things are, I don't know, to use a word from my generation, the bomb, right? They're awesome. To use a word from your generation, they're fire. I was teasing my kids last night, trying to say all the words that make them embarrassed of me in a public setting. So, but these are really going to help you a ton, because they break it up into groups. So these are the side effects that you need to be most concerned about. Gastrointestinal distress, again, is going to be very common with our antibiotics. So it's making the determination of, is this mild gastrointestinal upset that we can manage, right? To teach our patient different ways to manage them, like, hey, take this with food, take it with your meals, right? Or is this, a rash or anaphylaxis that really requires intervention? So gastrointestinal distress, management, right? Rash, call the provider. Anaphylaxis, go to the ER. Right? Thinking about what my nursing implications are going to be for those. The common super infections associated with penicillin are stomatitis and vaginitis. And then our risks with organ toxicity with this medication are hepato and nephrotoxicity. So these kind of really lay out exactly what you need to know in a very condensed form about each medication. They'll be very helpful to you, especially because as we progress, because there's more and more anti-infectives that we're going to talk about tonight, it's very easy to get these mixed up, right? So you could even maybe take these squares, cut them out, and put penicillin on a board and then do like a matching game or something like that. Mix them all up and say, okay, what do these go with? That would also be a good way to study and prepare. A fun game for your study group, right? Compliments of Professor Jensen. So different side effects associated with the medication, gastrointestinal stress. This also has some CNS effects. And so remember, we talked about this. We don't like to combine any of our medications with alcohol. Some are going to be worse than others, but anytime a medication has potential for CNS effects, we don't want to combine it with other medications or drugs that can increase those risks if we can help it. And alcohol is always something we can avoid, right? So make sure we review some of these, looking at these adverse effects and life-threatening effects. Anaphylaxis is the big one that I want you guys to remember for penicillin. That's why it's bolded, highlighted in red, okay? We talked about some of the rules associated with blood cultures. So identify the organism before antibiotic therapy, monitor for evidence of superinfection. So we're thinking about where we're going to see superinfection with each type of patient, right? So some medications we're going to say, hey, open your mouth. I want to take a look and see and make sure everything's okay. Or we're going to be asking our patient questions about vaginal secretions or things like that, just trying to figure out what's going on with our patient and if they're having any potential problems. We want to examine the client for an allergic reaction, especially if they've never had the medication before and it's a first or second dose. And we want to teach the patient how to appropriately take their antibiotics. Now, think about all of the potential options you have associated with antibiotics that could fall under the category of which statement by the patient indicates the need for more teaching. That would be a fun activity, right? You guys could all sit around in a study group and say, hey, what's something silly that my patient might say related to this medication that would be incorrect, right? Or what's something that I know somebody has done that I now know is incorrect related to antibiotics, right? So you can kind of predict what patients might say or what things you might have seen to help you identify what they're not supposed to do. You could make 2 tables, right, in a study group, and you guys could all write down some things like on flashcards and then put them, together and say, this is something that the patient should do. This is something that the patient should not do, right? So those are some things that you can do to prep and prepare. For our next drug, cephalosporins, we have cefotriaxone, which is also known as Rocephin, the brand name Rocephin. What type of drug is it and what classification? Well, it's a cephalosporin, so we already know that. So what type of drug is this?
Is it bactericidal?
Chuck, what are the indications for use of this medication? What do we give cephalosporin, specifically cefotriaxone, for?
Is it like surgical infection?
Yeah, so this medication can be given for infection, but it's often prescribed prophylactically. So when we talk about prophylaxis, we're talking about preventatively, right? So you may have patients who are getting this medication pre-operatively to prevent infection prior to a procedure like a hip replacement or really any type of surgical procedure. Will often give antibiotics prior to surgery, even if there's no evidence of infection, to prevent infection. So we already have it on board. It's fighting infection, potential risk for infection. With this medication, we have similar assessment criteria, right? Like, what are my patient's vital signs? What's going on with their body? What signs and symptoms of infection do they have? Looking at white blood cell count, taking blood cultures if that's indicated, right? How? Every time we give an antibiotic, our blood culture is indicated. No, but if blood cultures are indicated, we're taking them before administration of the antibiotic, right? So we have a patient who's going to surgery for a knee replacement and they don't have any signs and symptoms of infection. We don't need to take blood cultures on that patient, right? So we're taking blood cultures when we see signs and symptoms of infection to determine how we treat that infection. So it's not always necessary to get a full-blown culture to take antibiotics, right? Particularly blood cultures. All right, so let's talk about this drug a little bit. There are a bunch of different generations of cephalosporins. Cefotriaxone is a 3rd generation cephalosporin. It is bactericidal. Good job, bonus points to whoever said that. And it's used to treat otitis media, meningitis, appendicitis, gonorrhea, septicemia, surgical infection, prophylaxis, so preventing infection prior to procedure. This is probably one of the most common medications that I've administered pre-procedure working on a medical surgical unit. So I sent a lot of patients to surgery, and we usually had to give this one just prior to surgery. And then, of course, we have skin, respiratory, bone and joint, gynecologic, and urinary tract infections on this. So kind of thinking about some of these. Now, here's another one of these lovely concept maps that I think is, kind of fun for us to work with. Again, encourage you guys to print these out, cut them out, and play matching games with yourself. Like, what drugs do these go with, right? A big drug to drug interaction with this is alcohol. So remember I mentioned that we don't want to combine alcohol with any of our medications. There's no like safe indication for use of alcohol, really. Like, there's no benefit to it. I know there's some research to say a glass of wine for this or that. There's a lot of new and emerging research that's coming out that kind of disproves a lot of that, or kind of makes it more neutral. Like it doesn't make a difference one way or the other. But there are a lot of medications that interact negatively with alcohol. This is one of them. So it says it has a disulfiram-like reaction. What does that mean?
Nausea and puking.
Yeah, it's not pleasant, right? We're not talking about just a little bit of gastrointestinal upset. You might have acute cyclical vomiting, right, where you can't stop, associated with alcohol consumption. So that's important to remember. And then look at our different super infections associated with this. So we have stomatitis, right? sores in the mouth. Anal and genital itching are associated with this medication and can be a sign of a superinfection. So we're not talking about just a little bit of itch. We're talking about really severe, incessant itching. And then one of our favorites, C. difficile. This is very severe and debilitating diarrhea, right? You're a patient, you don't want this. All right, so we have our potential side effects of gastrointestinal distress, flushing, diaphoresis, right? A little sweating, a little fever, CNS effects, once again, edema, an injection site reaction. This medication burns quite a bit when it goes in. If you've ever had an injection of Rocephin, it's kind of painful. I've unfortunately had to give it to a few kiddos in my day or help hold kiddos when I've done it. Yeah, and I told you guys I didn't work in peds, but every once in a while you have to float random places when you're a nurse, or you have to trade services, right? There's only a few of us on the unit, so I'll come help you hold down a 4-year-old while you give them a couple of shots, and then I will, and then you can help me start an IV on my patient with dementia who's trying to punch me in the face while I do it. So, you know, sometimes we trade help in the hospital, right? I am not catching my breath. Really important adverse reactions highlighted, bolded in red to remember are C. difficile. And then thinking about, somebody asked, can you kind of give a brief statement as to what central nervous system effects? I don't want to spend too much time on this because we don't really get into this very much. So it's kind of a little bit higher level. But when we're talking about central nervous system effects, we're talking about effects on the brain, right? So either activating or depressing, right? And so when we think about central nervous system effects, when we've talked about them previously, like we've talked about, oh, you know, how does that actually affect the body? It can make things a little bit more sluggish, make the brain move a little bit more slowly, or it can kind of pick up and activate those synapses. You don't need to go too far down that rabbit hole for the purposes of this exam. What you just need to do is make sure that you recognize that they have central nervous system effects and that you don't want to combine them with other potential medications when you can avoid it, right? That can cause central nervous system effects. And alcohol is definitely one that we can avoid. Stevens-Johnson syndrome also potentially comes up for a lot of these medications as a potential side effect, or sorry, life-threatening adverse effect of the medication. This is where that, if you guys read the insert, if you've taken an antibiotic recently, or you're going to take one soon, or you know somebody who has, look at the insert and read it. My daughter was just prescribed an antibiotic the other day, and I was reading the insert because I'm a pharmacology nerd. And I saw, because they do the patient teaching in a way where they don't actually say, hey, watch out for signs and symptoms of Stevens-Johnson syndrome. But the education said, if you have any sloughing off of your skin, like if your skin just starts coming off, go to the emergency room right away. And I thought, I would hope anybody would do that if that ever started happening to you, right? But you never know. Okay. So other important things to remember with cephalosporins, disulfiram-like reaction. We can also see some flushing, dizziness, headache, nausea, vomiting, and muscular cramps associated with that. And then with certain types of medications, we'll see a decrease in cephalosporin excretion. Right? We have to culture the affected area before therapy is started. So if we're doing this for like a skin infection or something like that, we can culture the skin, we can culture the tonsils, right? We're going to culture the area. So sometimes we can do like a local culture. We could do a urine culture if the patient has a urinary tract infection or signs and symptoms of a urinary tract infection. We can get that culture so we can figure out the type of bacteria. We're going to closely monitor our patient for hypersensitivity reactions. So anaphylaxis, right? And then we're going to teach our client, like we are with all our antibiotics, finish the medication, follow the directions, take it as prescribed. And then look at this, advise the client to take medication with food if gastric irritation occurs. So if this is making your tummy hurt, take it with some food. Azithromycin, what is this medication?
Is it both bacteriostatic and bactericidal?
Yeah, so looking at this medication, we'll see that yes, it can be, and its indications for use are very similar to some of the other medications that we talked about previously. So same assessment criteria, monitoring those potential side effects. How do we know it's effective? We'll see a decrease in those signs and symptoms. We'll see a decrease in that white blood cell count. And we may see some complications associated with this drug, like any antibiotic, right? So typical side effects are blurred vision, ocular irritation. But look, there's some new ones here that are highlighted, right? These were highlighted on your PowerPoint, so they're going to be important for you to remember. So you're going to tie these to azithromycin. One of those is photosensitivity. We've talked about photosensitivity a lot. What is photosensitivity?
A skin reaction where you're very sensitive to the sun.
Yes, it has nothing to do with, you know, covering up our eyes, right? Or light flashing. And then tinnitus. What is tinnitus?
Ringing in your ears.
Yes. So ringing or buzzing, sometimes the patient will describe it as a buzzing sound. So those are two that I want you to pay particular close attention to associated with this medication. We'll see some potential adverse reactions associated with hearing loss. So this medication is also known for ototoxicity. So when we think of azithromycin, we're going to say, okay, photosensitivity, tinnitus, ototoxicity. How am I going to potentially assess those things on my patient? Well, I can ask them about it. I can teach them about it. I say, hey, if you notice some ringing or buzzing in your ears, I want you to call me immediately. You got to wear sunscreen while you're taking this medication. And if you start to have any problems with your ears, because tinnitus can be a sign of that ototoxicity, you need to come in right away. Now, life-threatening associated with this medications, we've got a bunch of different options here. Focus on hepatotoxicity, anaphylaxis, bronchospasm, right, breathing issues. And then, of course, we have our friends here, Stevens-Johnson syndrome. All right. Similar rules as with our other medications. We're going to obtain a sample of the infected area and send it to the lab before starting the antibiotics. Now, what does CNS stand for? Send it to the lab for CNS.
Culture and sensitivity.
We're going to monitor for vital signs, urine output, and lab values, right? What do they tell you when you're sick? Lots of fluids, plenty of rest, right? So we want good urine output because a lot of these medications can impact the liver and kidneys. We want to make sure that we're monitoring them closely. Now, we can monitor lab values, but we can also use our eyes, look at our patient and see how their urine looks, right? And the amount of urine that their kidneys are excreting. We also want to teach our patient that we want to administer antacids 2 hours before or 2 hours after this medication. Now, typically, we haven't learned about antacids yet, right? But typically, we separate antacids by 1 hour from most of our medications. In this case, there's a potential interaction with this medication, so we want to space it out even further. Full course of antibiotics. Encourage the client to report side effects, which means you have to know what those side effects are, right? So we talked about photosensitivity, we talked about tinnitus, right? Recognizing those signs and symptoms of ototoxicity. We also want the client to report the onset of loose stools or diarrhea, right? What does that sound like? What superinfection does that potentially sound like?
C. diff.
C. diff, okay? Our next medication, doxycycline. What type of drug is this? What is its classification?
It's tetracycline.
Tetracycline. And when we're taking tetracyclines, what's one of the big things that we have to watch out with tetracyclines? This medication is not safe. Yeah, go ahead, Daisy.
Photosensitivity as well.
Photosensitivity is a big one with this medication, and then this medication is not safe in pregnancy. Doxycycline is a pretty common medication, though. It's actually prescribed often for my brain just went blank. Acne, right? For patients who have especially bacterial acne. So sometimes we'll use antibiotics to treat that acne. When you think about assessment criteria prior to administration, so signs and symptoms of infection, what do we need to monitor, right? What lab values are we looking at? How do we know it's working, right? We'll see decreased signs and symptoms of infection, and then some of the complications associated with this drug. So tetracyclines is a classification. You may get questions, remember, about specific drugs or classifications of drugs. So make sure you know your classifications, right? We're looking at maybe 1, 2, 3 drugs in each classification, but there are a number of drugs in each classification. So you may see questions that just focus on the classification of drug. These drugs can be bacteriostatic or bactericidal. They're considered a broad spectrum antibiotic used to treat acne. This is probably the one that you're probably most familiar with. You probably know somebody in high school who took doxycycline for treatment of acne. And it does cause that photosensitivity. Sometimes patients will report that their skin is really dry or peeling while they're taking this medication. Is this ringing any bells from high school? It's also used to treat respiratory, urinary tract, and skin infections, and can treat cholera and some STIs. Okay. So our concept map is definitely going to be our friend. We're looking at things with doxycycline. We don't want to take this during first trimester of pregnancy. We don't want to take this medication if we're younger than 8 years of age. It's not safe in young pediatric patients. And we don't want to take with milk products or antacids because it actually interacts with the drug. So with this tetracycline, I really want you to pay close attention to these nursing considerations because there's a lot of teaching components here, right? And patients who we would want to avoid this medication with. So if you are a nurse and you have a patient and they're 6 years old and they're prescribed this medication, you know it's not safe for that age group. That might be an error or a mistake on the part of the prescriber. So you want to alert them, right? You also want to teach your patient, yes, you can take this medication with food, but no, you cannot take it with milk products. So it doesn't play well with milk, right? And we want to avoid antacids while taking this medication, right? Looking at some of our potential side effects, tooth and nail discoloration is one of the big ones that people are most concerned about, but we also want to think about things like photosensitivity and glossitis. We also see some of our typical ones like gastrointestinal distress, but headache on here is new as well. And then look at our organ toxicity. This is a high risk drug for organ toxicity. Super infections, we want to tie our super infections to our drugs, so stomatitis and anal or genital discharge. Now, super infections are not an expected side effect of the medication. These indicate a very serious potential problem. And so we need to alert patients to the signs and symptoms of the super infection. We need to monitor our patients for those signs and symptoms, and we need them to call us if they experience. We want them to report those symptoms. All right. So here's some of the discoloration we may see associated with doxycycline. Unfortunately, it could be permanent. And this is part of the reason why we don't give it to our very young patients, because we don't want that to occur on their permanent teeth, right? We also may see some dry mouth. Photosensitivity is a big one for us to remember. And then of course, our life-threatening ones that we keep seeing over and over again, anaphylaxis and Stevens-Johnson syndrome. You can see how you can really start to mix these medications up, right? Because there's so many commonalities. We try to highlight and bold the things that are really essential and important for you to remember about the drug. So please, as you go through and study and prepare, pay close attention to that, right? Because that's there for a purpose and a reason. All right, so tetracyclines, no milk products, no antacids, oral contraceptives. We're going to take that backup method of birth control. We're also not going to combine it with these types of medications, penicillins or aminoglycosides, okay? All right, same nursing interventions or similar nursing interventions, right, to what we've seen before. So blood cultures first, right? Keep saying that over and over again. I bet you that's going to be on your exam, right? Monitor lab values for renal and hepatic function, record vital signs in urine output. Hey, look at this one. We have a new one here. Inform female clients who are contemplating pregnancy to avoid taking tetracyclines because it can cause discoloration of permanent teeth. All right, encourage the client to take entire course of the antibiotic. All right, Bactrim, our TMP SMZ medication. That looks like a combo medication. So trimethoprim, sulfamethoxazole. That's a mouthful, right? That's why we call it Bactrim or TMP SMZ. What type of drug is this?
Sulfonamide?
Mm-hmm. And this medication is used for what types of infections?
MRSA.
Yeah, this is actually one of the few medications that can treat MRSA, right? So that's a big one that I want you guys to remember. So assessment criteria and monitoring we'll talk about a little bit, but a lot of these remain the same, right? So this is a bactericidal medication, so it's going to be strong, right? It can be used to treat ear infection, meningitis, respiratory and urinary tract infections. I've actually seen this medication prescribed quite frequently for UTI. And a big one here is MRSA, right? We see a really bad infection, right? That's resistant to other types of antibiotics. This is a good medication for that. All right. So this is a sulfonamide. Good job, ding, ding, ding to whoever remembered the drug classification. And we're looking at how this medication decreases the risk of resistance, which makes it a good drug for super infections like MRSA, right? And so that's one of the things that's highlighted in most important. But some other things to remember. Look at these nursing considerations, right? We see photosensitivity, tinnitus, vertigo, rash. We've seen some of these before, right? So we'll have to tie those to this classification of medication. We have a lot of potential super infections with this medication. Stronger antibiotic equals greater risk for super infection, right? Are we making that correlation, right? And then we get the super infection, and then we have to treat the super infection with strong antibiotics. It's a vicious cycle, right? So strong antibiotic, greater risk for super infections. But look at these nursing considerations. Look at what lab values we're going to pay close attention to. And this can also increase the effects of oral hypoglycemics. So why would we be taking an oral hypoglycemic? What's that medication for?
Diabetes?
Yeah, it's a diabetes medication. It's an anti-diabetic medication. Oral medications, we're going to talk about in the next unit, but those are for type 2 diabetics. But this can increase the risk of a lowered blood glucose level for our patients. So that's an important interaction for them to know about, right? So if I have a patient who is a diabetic and they need to take Bactrim, what am I going to talk to them about? I'm going to talk to them about how this can increase the effectiveness of their oral hypoglycemic. So we can do one of two things. We can switch the patient to insulin, that's an injectable, right? Or we can more closely monitor their glucose levels, right? It's a little bit harder to adjust the dose on an oral hypoglycemic, right? With insulin, we can just decrease the amount of insulin that we give, but when we're taking pills, it's hard to decrease the dosage. Another thing with this medication, look at these instructions. Take with a full glass of water, and look how much water we have to drink with this medication per day, right? So really increase our fluid intake. We're also going to closely monitor nephrotoxicity. Look, we're tying this for, okay, this can be toxic to my kidneys and I have to have a minimum fluid intake with this medication, right? So I'm trying to help my kidneys out here by drinking all this water. We also want to watch our patient for signs and symptoms of ototoxicity. Signs and symptoms of ototoxicity include tinnitus, right? One of the big things with this that's bolded in red, remember, decreases the risk of resistance, right? All right. Some more fun things associated with this medication is some of our side effects. We may have vertigo. This one also has photosensitivity listed. I've got my little picture blocking the way. And then no real like listed adverse effects, but lots of potential life-threatening effects. So if we look at this, anaphylaxis, seizures, myocarditis, hyperkalemia, hyponatremia, hypoglycemia, those are kind of a big deal, right? So our fluid and electrolyte balance is really important. And then we've got our friend over here, Stevens-Johnson syndrome, right? Vertigo, again, we remember from health assessment is that room spinning sensation, which is what that picture is supposed to indicate. So with this medication, you're going to make sure that your patient takes it with a full glass of water. That will be part of their insert when they take the medication home, but you want to make sure that they do it because this medication can be harmful to the kidneys, right? So we're drinking lots and lots of water, a minimum of 1,200 mLs a day. That's the minimum, right? We have to closely monitor if our patient's in the hospital, their intake and output. We have to look for hematologic reactions, check for signs and symptoms of a super infection. We can go back to our concept map and look at what specific types of super infection we're watching out for. We don't want them to take any antacids with this medication. And then they're going to wear sunglasses, avoid direct sunlight, use sunblock, and wear protective clothing in the sun. So we're protecting our skin, right, with this medication. All right, new question for you. What is tuberculosis and how is it transmitted? How do you determine if your patient has tuberculosis?
Isn't it airborne? And can be like community acquired?
So a lot of people think TB is airborne.
Or is it droplet? I don't remember.
Droplet precautions for TB, right? So back in the day before COVID was a thing, TB patients were the most frequent reason why I, as a nurse, would wear an N95 mask with a patient. We also have to have them in a HEPA filtration room, right? So that the air that goes out is recycled back in, because droplet precautions can still cause that, but it's spread through their sputum, right? How do you determine if your patient has TB?
X-ray?
You can do a chest x-ray. What's like a cheaper and easier thing that we can do? You guys have all probably done it unless you're allergic to it.
The
Oh, like
TB
the
test.
subcutaneous?
Yeah, TB skin test, right? Now, what's the problem with the TB skin test? Takes a little time, right? We have to read it in 48 to 72 hours, right? So TB skin test is one of the first interventions. If you suspect your patient has TB, we're gonna give them a TB skin test. It's cheap, it's easy, right? So it's a quick way for us to determine maybe if they have potential. Now, we get false positives with TB skin test. If it's positive, we'll do a chest x-ray on the patient. All right. So tuberculosis is a bacterial infection. It's transmitted person to person via droplets. So coughing, like I'm doing right now, but I don't have TB, I promise I've been tested. Sneezing and talking, right? So when you go into the patient's room with tuberculosis, you're gonna be wearing an N95 mask, right? Clients at risk are those that are immunocompromised, living or working in high-risk residential settings, those who inject illegal drugs, or healthcare workers with high-risk clients. So you guys are going to be at risk for contracting TB because you'll be interacting with patients who have TB. The most common patients that I've worked with that had tuberculosis were homeless. A lot of the homeless population, at least where I live, that's one of the issues that we see. Now, TB is treatable, but it is hard to treat. It is hard to get a patient into remission with TB. So it's really important that we try not to spread TB, that we don't transmit it to our patients, that we're careful in following those contact precautions, those droplet precautions with our patient, that we keep those negative pressure rooms closed up, and that we really follow those rules and regulations, because you don't want TB. The course of treatment for TB can last a really long time. So we're gonna talk about that. How long is the treatment for TB? And how do we know that it is working? What tests do we run?
Is it 6 to 9 months of treatment?
Yeah, it could be up to a year actually for TB treatment, taking antibiotics. Now, you see a potential problem for a patient like the typical population that I saw who was contracting TB, or some of these others that we looked at, injecting illegal drugs, living and working in high-risk residential settings, maybe poor access to care, right? So you can see some potential problems with the continuation of the spread of tuberculosis, right? So it's more common in countries that are not fully industrialized, where the spread of disease is more prevalent, right? So impoverished areas. How do we know that the treatment is working?
Did you do like sputum samples and
Sputum cultures, right? So we're gonna test we're usually first morning sputum. So our patients are coughing up some lovely stuff. If you guys have seen the movie Tombstone, you've seen Doc Holliday, he coughs up blood, but it doesn't look like that. It's more like a rust colored sputum early on in the disease progression. Now, eventually, because there wasn't a treatment for DB at the time, you'd end up coughing up blood and potentially some lovely lung tissue, right? But since we can treat it, sometimes we'll see patients with like a rust colored sputum, but we want to take samples and send them off and test them. Now, one negative sputum culture is not good enough. So we have to have multiple negative sputum cultures, but those are one of the tests that we run. All right. So symptoms of TB: cough, fever, night sweats, gastrointestinal distress, and we often see a lot of weight loss in these patients. They're very weak. We also see positive acid-fast bacilli in the sputum or bloody sputum. We see some blood tinged or rust-colored sputum. Sometimes we have to do prophylactic treatment. So if you're taking care of a TB patient and you didn't know they had TB and you didn't wear a mask, you might, as a nurse, have to do some prophylactic treatment. So if you have close contact with active TB, sometimes we do this for patients who are severely immunocompromised to prevent them from getting TB. Because if we look at conditions like HIV, it's not often the HIV that kills you, it's the secondary infections that you get as a result of being immunocompromised, right? And then we'll see sometimes with latent TB infection, injection drug users, sometimes we'll do some prophylactic treatment. Or if we have somebody that comes from an area where there's a high prevalence of TB, you may be required to do some prophylactic treatment. So we do utilize it, right? Now, our medication that we use to treat TB is our INH or isoniazid, okay? So this medication is one of those key medications that's utilized to treat TB. We won't get into all these questions. We'll kind of start to break it down. But this is an anti-tubercular medication. It's used to treat active TB and as a prophylactic measure against TB. So it could be for both. This is bactericidal or bacteriostatic, depending on drug concentration. So you can imagine if we're taking it prophylactically, we're probably doing a lower dose of the medication if we're taking it to prevent, right? But if we're taking it to treat active TB, we may have a much higher dose, right, of the medication. This medication is also very well known to cause photosensitivity. So I want you to think INH, photosensitivity, and tinnitus, ototoxicity, right? So problems with the sun, problems with tinnitus, and think about how long we potentially have to be on this medication, right? Long periods of time on this medication. Teaching your patient to closely follow the medication regimen is going to be a big deal for our TB patients. Now, there are some kind of different adverse reactions associated with this medication. So it can maybe cause some psychotic behavior, peripheral neuropathy. The big one that I want you to remember is a vitamin B6 deficiency. This deficiency is so serious with this medication that while you're taking it, you're going to be taking a vitamin B6 supplement. It's like the two they're best friends. They're always together. We take them together, right? So that's going to be something that you're going to anticipate, and you're going to be closely monitoring your patient's vitamin B6 levels, okay? It can cause some hyperglycemia, which could be a potential risk for our diabetic patients who are already experiencing hyperglycemia, so metabolic acidosis, and some other severe reactions. But the big one you need to focus on that's bolded is our vitamin B6 deficiency, okay? So with our anti-tubercular drugs, we need to obtain medical history, assess for hearing changes if drug medication or drug regimen includes certain types of medication, including streptomycin, right? So these drugs carry a risk for ototoxicity, so we want to bear that in mind. There's going to be a lot of patient teaching surrounding tuberculosis and the treatment of tuberculosis. Now, we have to have negative sputum tests, and they have to be negative for 2 to 3 months after prescribed anti-tubercular therapy for us to determine that the patient doesn't have a latent infection and that it's not coming back. So you can see how you could be on this medication for an extended period of time. We do not take this medication with food. So administer 1 hour before or 2 hours after meals, never at the same time. We have to give the vitamin B6 as prescribed with the INH to prevent peripheral neuropathy from occurring. So a vitamin B6 deficiency equals peripheral neuropathy for our patients, okay? We're going to monitor hepatic function tests. This medication is hard on the liver, so that's something you need to remember as well. And emphasize the importance of compliance with the drug regimen, knowing that we could be taking it for a very long period of time, right? We're also going to teach our patients about side effects like photosensitivity, right? With this medication, tinnitus, report any hearing loss or problems with the ears, okay? And they can be actually, my notes say that they can be on this medication for 9 months to 2 years. So it's possible to be on this medication up to 2 years. That's a very long time. All right, let's shift gears a little bit. What are signs and symptoms of a fungal infection? we think fungal, what do we think? What's some different types of fungal infections?
I think like skin, like nail infections and like feet infections. I always
Mhm.
think skin.
Yeah, under the nail beds is a common place, or between the toes, right? Where moisture can get in. So things like athlete's foot is a fungal infection, right? What about yeast infections, right? We can get yeast infections in the oral cavity, in the vaginal cavity, right? In the folds of skin, we can also get yeast infections. So dark, moist places can often grow fungal infections, right? We can also get them in our lungs, right? Which is not pleasant for our patients. All right. So we think fungal infections or candidiasis. We're thinking about mucous membranes, so hair, nails, and moist skin areas. So if you have a patient who has like a large pannus, look under the folds of their skin and make sure that they don't have any fungal issues, especially if they're not able to perform a lot of self-care tasks, right? Really important if we're giving bed baths to patients that we clean them very well, but that we also dry between those skin folds. Because I have a preteen and a teenager, and I am telling you that I tell them every time they get out of the shower to dry between their toes, to get their feet completely dry before they put on socks or anything like that, because that's a recipe for potential fungal infections if you just trap those inside a shoe, right? So drying skin is going to be very important. We also see potential for thrush. There's a lot of medications that if we take for a long period of time, including some of our anti-infectives, that can cause this to occur. So thrush can occur in the mouth. It's very common in infants actually to experience thrush. And then we can get very severe systemic infections that affect the lungs, the abdomen, and even the central nervous system. One of the most common medications that you'll be giving in nursing is nystatin or mycostatin. This is a medication that's used to treat fungal infections. Okay, so what is this medication? What route do we give this medication? What do we know about nystatin?
Oral, and I've seen it in a topical, like an ointment.
Yeah, so those are some of the most common ways. And with this oral medication, one of the key things that we have to remember about it is that it's an oral suspension. So we can swish and spit or swish and swallow. Now, I want you to think when you're giving this medication, like when you're doing when you're at the dentist and you're like, they give you like a fluoride treatment, right? You swish it around really good, sometimes for a full minute before you spit it out. We want our patients to swish this medication around in their mouth and really get a good coating. So you don't want them to just, and then spit. They can also swallow this medication. And depending on what the provider's instructions are, sometimes it'll say swish and spit or swish and swallow, or the provider may want them to go ahead and swallow the medication. It's not super pleasant tasting, but most oral medications aren't. And we can also apply this in a thin topical layer. So if we have patients who have thrush is actually really common in oncology patients. They're at risk for a lot of fungal infections, especially if they're doing chemotherapy, because they're very immunocompromised. So you'll be giving this medication a lot. Nystatin is also found in what's called a magic mouthwash. You don't need to know about this, but I just think it's a cool thing. And it has nystatin in it, so an antifungal, but it also has some pain relieving components to it. So if you have a patient who gets a really bad infection, HIV patients, it happens, oncology patients, it happens where they get a lot of sores and soreness associated in their mouth. This actually has some numbing components to it as well to sort of help alleviate the pain and treat the fungal infection at the same time. All right. So nystatin PO administration can cause diarrhea, nausea, vomiting, and dyspepsia. So it's sometimes swishing and spitting can be a little bit more pleasant on our patients. And then topical administration, we can maybe see a side effect of some skin irritation. Anytime we put a topical ointment on a patient, it can cause some irritation, especially if they tend to have, some people have more reactive skin than others. And then life-threatening is angioedema, bronchospasm, sinus tachycardia. And then our good old friend, Steven Johnson, right? So, all right. What about fluconazole or diflucan? What type of medication is this?
Antifungal.
Antifungal. We're still on antifungals, right? So diflucan is or fluconazole right? For our generic name, which is what we focus on, is used for candida infections and cryptococcal meningitis. It can also be used for prophylactic for patients undergoing bone marrow transplant or radiation therapy, so to prevent those things from occurring. This is contraindicated in pregnancy and cardiac disease, or patients who have renal and hepatic disease, which will probably give us a pretty good clue that if these patients already have problems with these organs, that this drug may be hard on those organs, right? Look at this, we have some side effects that are listed, but we have one in particular that's highlighted for us. So hypokalemia. Hypokalemia means what in layman's terms?
Low potassium.
Low potassium. And why is low potassium a potential problem?
Cardiac issues.
Yeah, that's going to be like the big thing with that. Precursors to issues with potassium levels. A lot of times patients will describe that they're feeling some muscle cramping, right? If you have a patient who's complaining of cramping and they're taking a medication that can raise or reduce potassium levels, we might want to check serum potassium level on the patient. Herb interactions. This looks fun. Increases serum caffeine. I need that in my life, but it says to avoid caffeine. Green tea, soft drinks, or really anything, energy drinks. And don't get me started on energy drinks. I think they're the devil, but I drink a lot of coffee, so I can't really judge. But we want to avoid coffee or caffeine with this medication. So those are some things that are kind of unique to fluconazole that I think we want to pay close attention to, right? Hypokalemia and avoiding caffeine while taking this medication. All right, advise the client to take the drug as prescribed if they're taking antifungal, whether it's topical, swishing and spitting, or if they're taking it orally or through the IV. Advise the client not to consume alcohol. That's just a good rule of thumb for all of our medications, right? Encourage the client to report side effects. What were those side effects? Oh, headache, rash, GI distress, and hypokalemia. A patient's not going to be able to know I have hypokalemia. So what are those potential signs and symptoms that they would know? Observe the client for evidence of side effects and check the client for the potential super infections that may occur. Now, here's one that we might be familiar with too. I just saw a TikTok video where they asked like 5 or 6 different nurses how they pronounce this medication, and everybody said something different because Flagyl is just so much easier to say. But metronidazole is what type of medication?
A peptide.
Bonus points. Okay, so looking at this medication, and I leave these questions up here, but we're not going to go through every single one for each medication. But I do want you guys, this is how I want your brain to think when you're looking at each one of these medications, right? So this interferes with bacterial wall cell, it interferes with the bacterial cell wall, causing cell death. This is actually an antiviral, antimicrobial, antifungal, and antiparasitic. So wow, that's a lot of things, right? This is a pretty powerful medication, right? So this is used for bactericidal or anaerobic infections. This is contraindicated in the first trimester of pregnancy and with lactation, so it's not safe for infants. We have to use caution in patients who have liver impairment, cardiac conditions, and neoplastic disease. Well, why? Potential side effects are headache, nausea, flushing, and dizziness. Ooh, look at our friend here, disulfiram-like reaction. So we're not going to drink alcohol with this medication, right? And then super infection, we may see some white patches on the tongue. So you might ask your patient, hey, let me look at your tongue, right, while they're taking this medication. Adverse reactions are some of the things that we have seen before, except now we're talking about optical and peripheral neuropathy, okay? We are going to monitor LFTs, so liver function tests, right? AST, ALT, ALP, BUN creatinine, and platelets with this medication. Now, big things. Client safety. To avoid antibiotic resistance, counsel clients to ask their healthcare provider if they can be treated without antibiotics, right? Let's avoid them if we can. Take them if we need them, but avoid them if we can. Take them fully as prescribed, never skip doses, and never share antibiotics with your friends, right? All right, we are going to take a 6-minute break, 5.5-minute break. We'll come back at 6:15, or sorry, 5:15 your time, 6:15 my time. So if you guys need to go take a bathroom break, anything like that, we'll come back and we'll start getting into some of our cardiac medication. So 5-minute break, back at 5:15. Okay, guys? All right, guys. Come back, come back. I know your brains are fried, but we still have more. We're a little more than halfway. Well, we're about halfway through. So, but I feel like this section is a little easier in terms of understanding and things like that. So, what are some signs and symptoms of heart failure, and what are some non-pharmacological interventions for the treatment of heart failure?
You can fix diet, like decrease salt, saturated fat, alcohol, stop smoking, increase exercise.
Yeah, all those good things. Low salt, low fat, low flavor diet, and a little bit of cardiovascular exercise, not to excess, right? But those are some good potential interventions. So how heart failure works, just quick review. A little bit of AMP for you, right? The heart muscle weakens and gets bigger, right? Loses its ability to pump blood adequately, and our compensatory mechanisms fail, so the lungs in the periphery become congested, right? Right-sided backs up into the periphery, left-sided backs up into the lungs. So you're learning about some assessment in health assessment related to this, and so this is kind of beneficial, they coincide. Non-pharmacological treatments limit salt and saturated fat, limit or avoid alcohol intake, stop smoking, always stop smoking, and perform mild exercise. Digoxin, one of my favorite drugs to talk about. What type of drug is it? What is its classification?
Cardiac glycoside.
Cardiac glycoside, bonus points. What are the indications for use of digoxin?
Heart failure and AFib.
Yeah. I was like, could it be that big thing that we just talked about, heart failure? Yes, definitely. So what assessment criteria do we need prior to administration of digoxin? Digoxin has some safety concerns. So what assessment criteria do we need?
Baseline of all the vital signs.
And in particular, which vital sign?
The apical pulse.
Apical pulse, right? We listen for a full minute to apical pulse, right? Because we need to know what our patient's heart rate is. And if it is below 60, we don't give the medication, right? What kinds of things do we have to monitor while taking this medication?
The serum digoxin and serum potassium levels.
Yes, digoxin impacts potassium, and potassium impacts cardiovascular function, right? Now, we also have to monitor that serum digoxin level. What's the goal or target serum digoxin level for a patient with heart failure?
0.5 to 1 nanograms per milliliter.
Good job. And how do we know digoxin is working?
Would it decrease the heart rate and increase the cardiac output?
So that's how digoxin works, but that's not how we know that it's working. So we talked about this a little bit in class. We don't want to confuse that mechanism of action for what our goal is associated with the medication. So we don't take digoxin to lower the heart rate, but digoxin works on the heart by lowering the heart rate, right? So why are we taking digoxin? What's wrong with our patient?
They're having heart failure.
Yeah, they have heart failure. And what are those signs and symptoms of heart failure, right? Fluid backing up into the periphery, blood backing up into the lungs, right? So we would like to see that the lungs become less congested, or there's less fluid backing up into the periphery, right? So maybe lung sounds will improve in my patient. Edema will decrease in my patient, right? Those signs and symptoms of heart failure will decrease. Oxygen demand on the heart will decrease, right? So that's a common misconception with digoxin. Oh, we're taking it to lower the heart rate. No, digoxin helps to solve the problem of cardiac insufficiency by lowering the heart rate and increasing contractility. That's not the goal. The goal is to improve the signs and symptoms of heart failure by reducing the oxygen demand that the heart requires, making the heart more efficient, right? So students make that mistake all the time. That's why I ask it, and that's why I want to point it out, because it's really important that we differentiate between what the goal of the medication is and how the medication works, right? What are some complications associated with digoxin? I just got really excited. There's thunder and lightning outside. It might rain. It's been like 105 here. Sorry.
There's that weird thing with like yellow vision.
Yeah, yellow vision, blurred vision, nausea, vomiting, those can all be signs of digoxin toxicity. And we also talked a little bit about how digoxin can interfere with our potassium levels, right? So that can be a potential complication. So we take this medication for heart failure and atrial fibrillation. For the most part in this class, we focus on heart failure. It's important to know that it's also for atrial fibrillation, right? And kind of how the medication works is vital for us to know. So it basically promotes increased forced cardiac contraction and increases cardiac output. So it makes our tissue perfusion better, right? So patient who's taking digoxin should be able to breathe a little better. They should have reduced edema. Their lungs should be clearing up, right? That's the goal. We're trying to reduce those signs and symptoms of heart failure. Now, you guys are right. Therapeutic serum level, 0.5 to 1 nanograms per milliliter. Do you have to have this memorized? Yes, you do. So if you didn't, you need to go back and make sure you have it memorized. So effects on the heart muscle: increases myocardial contractility, decreases heart rate, decreases conduction, and increases cardiac output. This is how digoxin works to reduce heart failure signs and symptoms, right? Contraindications are ventricular fibrillation. We also kind of want to avoid or use with caution in patients who already have some other types of cardiovascular issues, like in an acute MI. So post MI, you know, this different, but during an acute MI, we want to be careful with this medication and lowering the heart rate, things like that. AV block, hypertension, hyperthyroid, because that impacts heart rate, hypothyroid, because that impacts cardiac functionality as well, renal and hepatic dysfunction, bradycardia, right? We want to avoid taking this medication if our patient's heart rate is below what?
60.
Now, what if I told you in a question that the patient's heart rate was 65? What would you do?
Give it.
Give the medication. So sometimes we have questions like that, right? Where it's like, here's all your assessment criteria with your patient. What's your next step? And it's like, oh, just administer the dose. And you're like, it can't be that. It can't be that. They wouldn't ask me that question, but we do sometimes. So, you know, trust yourself. Okay. And then we want to be careful with older adult patients. Although most of the patients that I've given digoxin to have been older adult patients, they are at greater risk for some of those negative side effects associated with the medication, especially because we have reduced renal and hepatic function, right? So important things for us to remember. Now, digoxin side effects include CNS effects, gastrointestinal distress, and blurred or yellow vision. Adverse effects of this medication include bradycardia. So I have given this medication to patients and seen their heart rate drop pretty low. That's why we avoid giving it if the patient's heart rate is already below 60, because you don't want to kill your patient. I have seen students in simulation accidentally kill their patient with digoxin because they didn't do the assessment criteria. Now, if you go to clinical, your clinical instructor is not going to allow you to kill your patient. Just as a side note, these little digoxin vials are in ampules. They are made of glass and you do have to break them. So you guys will review how to do that appropriately and safely in lab if you haven't already. Probably in med surg if you didn't do it yet this semester. I have seen nurses cut themselves on these vials. So to be very careful, there's a little bit of a perforation, but injury can still occur. So make sure you're very careful in opening your digoxin if you're giving it through the IV. Life-threatening effects are cardiac dysrhythmias and thrombocytopenia, right? So sometimes we can reverse the effects of digoxin if our patient is experiencing too much bradycardia, because there's a potential antidote to this medication, which is digoxin immune fab. If there's an antidote, do we need to know it? Yes, all right. And then our common signs of toxicity: anorexia, vomiting, diarrhea, blurred vision, green or yellow halos, bradycardia, and abnormal heart rhythms. So we're going to teach our patient, if they're taking this at home, what are we going to teach our patient? What are they going to do?
Take their pulse.
Take their pulse prior to administration of the medication. If it's less than 60, we're going to withhold the medication, right? They probably need to call their doctor and let them know, hey, I had to miss a couple of doses of my digoxin because my heart rate was too low. And then maybe they need to be seen. We also want to teach our patients signs and symptoms of digoxin toxicity. So think about things that your patient might say that could potentially indicate digoxin toxicity to you. Like, I'm just having a really hard time reading this menu at the restaurant or in the hospital setting, right? Everything just feels kind of blurry, or they're kind of squinting, right? You're like, hey, are you having some problems with your vision? Like, if you have any blurred vision, you need to let us know right away, right? If anything looks yellow. I've seen a HESI question one time where they had a patient say, wow, those curtains look really dingy and they look really yellow, and the curtains were white, right? And you're like, oh, that yellowing of the vision, that could potentially be a sign of digoxin toxicity. Lots of potential interactions with digoxin. CAM interactions, in particular, ginseng can increase the digitalis levels. Digitalis and digoxin mean the same thing. So we're increasing those digoxin levels, which means that we are at an increased risk for digoxin toxicity if we're taking ginseng and digoxin together. So we're probably going to teach our patient to avoid that, right? We also see decreased absorption with St. John's wort. St. John's wort is just not friends with a lot of our other medications. So we probably want to try to make sure that we talk to patients about it and just say, hey, don't take this without talking to your provider first. But look at this one, psyllium. What does psyllium do?
It's fiber.
So fiber can actually decrease the absorption of digoxin, right? Now, if you have patients who have cardiovascular issues, do we sometimes give them fiber potentially? Right, to help to reduce straining maybe while they're going to the bathroom, right? So that's something to consider too, is that potentially combining these medications can decrease the absorption of digoxin. Increased effects of digoxin are seen with hawthorn, and increased risks of digitalis toxicity are associated with licorice, aloe, and ephedra. I'm not a huge like black licorice fan, but a lot of older adult patients really like black licorice. So I find that I have to do a lot of teaching on black licorice. My grandpa is one of them, like stop with the licorice. It impacts your medications. So we have to check apical pulse rate before administering digoxin. Don't administer if heart rate is less than 60. Big time rule, bolded, important, underlined. Do not administer if heart rate is less than 60. We also want to determine signs and symptoms of peripheral and pulmonary edema. We want to monitor the serum digoxin level. We have to know what that digoxin level is. We want to monitor serum potassium levels. So what's a normal potassium level for our patients?
3.5 to 5.
3.5 to 5 milliequivalents per deciliter, right? So if it's higher or lower, that indicates a potential problem and a risk for cardiac issues, right? We also want to teach our patient to eat foods that are high in potassium. So what are some foods that are high in potassium?
Spinach, avocado, potato.
Potatoes, yeah, potatoes are really good ones, bananas. So, start thinking about some things that we could potentially teach our patients, right? Instruct the client to report side effects, which means you have to know what the side effects are and be able to put them in terms that the patient can understand, right? All right, nitroglycerin. What is this medication used for?
Angina?
Yeah, for chest pain. Yeah, this medication is good for chest pain. What's this classification?
Anti-anginal.
And so we're giving this medication for chest pain. We can also give it when a patient's having like an acute MI, things like that. But what assessment criteria do we need prior to administration of this medication?
Heart rate,
Heart rate and
blood pressure.
blood pressure, right? This medication can drop your blood pressure really rapidly. In fact, one of the key side effects associated with this medication is headache. And headache is often caused by vasodilation, right? A lot of the medications that we take for headache can cause vasoconstriction to help to reduce some of that pain, right? This is vasodilating. It helps to reduce oxygen demand to the heart. What are we going to monitor in our patient while they're taking this medication?
Vitals and their pain.
Vitals and pain, right? So how long, if we're taking this medication sublingually, for example, should we wait before we assess whether or not it's taken effect in our patient?
Like 5 minutes.
5 minutes after the first dose, right? So we mostly with this medication, this is kind of one of those rare conditions where we're like, how do we know if the medication is effective? Well, we know by the reduction in their pain, right? The signs and symptoms that they report. What are some complications that are associated with nitroglycerin?
Hypotension, rash, syncope.
Yeah, syncopal episodes, hypotension, right? So what position do we want our patient in when we're administering nitroglycerin? If we're doing a rapid acting nitroglycerin?
Seated or lying down?
Yeah. What are our routes of administration or formulations for our slower acting nitroglycerins? Extended release. Do you remember? We have a nitro paste, right? That we can actually put on the patient's chest, and a nitro patch, transdermal patch, right? That we put on the chest. We want to rotate sites. Do we leave the patch on 24/7 on our patients?
No.
All right, yeah, we have to take it off, right? Give them a break, and then we put it back on the next day. So remember, we talked about the documenting the removal of the patch and the placement of the patch. So really important that we document the location, right? Also, you guys are going to sign your name to a lot of things. When you change a dressing, you're going to put your initials, date, and time on it. When you put a patch on a patient, you're going to put your initials, date, and time on it, even teeny tiny little medication patches. So carry a Sharpie with you because you're going to do that. I recommend writing it on the medication before you put it on, so you don't have to tickle your patient while you're drawing on it. And then you can let it dry a little bit before you actually apply it to the patient, right? Always make sure you remove the old patch. Give some space and time between doses, right? If you're supposed to be removing the patch and you can't find it, you really do need to try to look for it in the bed sheets or make sure that it was documented correctly, because you don't want to double up doses on the patient, right? Especially if it's been left on them overnight when it's not supposed to be, right? All right, so nitroglycerin to control angina, acute MI, hypertensive crisis, because it lowers blood pressure fast, pulmonary edema, and heart failure. Remember, this is the drug that I told you about, the nurse that was putting nitro paste on her patient and she passed out. So wear gloves when handling nitroglycerin. Actually, just wear gloves when you're handling any medications. But this works by decreasing myocardial demand for oxygen, right? It just decreases the pressure. This medication is contraindicated in increased intracranial pressure. Remember, this can cause headache, right? Anemia, cardiomyopathy, and shock, right? When we think shock, we think low blood pressure. We don't want to lower the patient's blood pressure. We want to use caution in renal and hepatic disease and in acute MI, hypovolemia, head trauma, and pregnancy. Now, we do give this medication often in acute MI, so I want you to hear me on this, that we're using caution. If we're having a patient who's having acute MI, we are with that patient, right? We're not leaving them alone in a room. We're staying with them while they're dealing with that. Routes of administration are sublingual, topical, aerosol spray, transdermal patch, IV, buccal, and oral extended release capsules and tablets. So remember to differentiate between your rapid acting, extended release, things like that. Side effects, we already talked about them. CNS effects, including headache, hypotension, flushing, and rash. Syncopal episodes, seeing patients pass out after administration of nitroglycerin. Blurred vision and dry mouth, that sounds like anticholinergic effects, right? Palpitations and peripheral edema, and tolerance. If we have patients who take this medication frequently, it will become less and less effective for them over time, right? Adverse reactions include orthostatic hypotension. Remember what we're going to teach. Orthostatic hypotension is about to come up a lot because we're talking about cardiovascular medications. Anytime we have a medication that can lower blood pressure, reduces oxygen demand, we carry the risk of orthostatic hypotension. So we have to teach our patients not to get up too quickly. This medication can also cause some tachycardia or paradoxical bradycardia and circulatory collapse, right? We can just completely eliminate that pressure if we're not careful. What will you teach your patient about nitroglycerin?
So if they have it at home and they're having an MI, they need to take the first dose and call 911 before taking the second dose.
Yes, that is very important, right? We talked about this in class a little bit. If they start to feel better after the second dose, they don't have to go to the hospital. But if they're having chest pain and it's not alleviated by that first dose, they need to call 911, right? If you're giving this medication in the hospital for a patient who has chest pain, you are staying with that patient. you have your doses of nitroglycerin, and you are not leaving the room, right? Because you need to make sure that your patient's chest pain is alleviated by that first dose, second dose, third dose. After the third dose, we are looking at potential risk for MI, right? Patients who report chest pain in the hospital, we should have a pretty rapid response time for them, right? Because we're like, hey, well, we administered nitroglycerin, it didn't get better. We can do an EKG, we can do all these things right away. We can check troponin levels, we can do all that fun stuff, right? So nursing process for nitroglycerin, vital signs, vital signs, vital signs. We're taking vital signs between every dose of the medication if we're the ones administering it, right? So we're waiting 5 minutes, checking vital signs, doing the next dose, right? We also want to position the client sitting or lying, right? Especially when taking the medication for the first time. Monitor effects of IV nitroglycerin, report if angina continues, administer sublingual nitroglycerin tablet if chest pain occurs. Advise the client not to ingest alcohol. This medication has CNS effects, so we're not going to do alcohol with it. Instruct the client on proper storage of nitroglycerin tablets. What will you teach your patient about proper storage of nitroglycerin tablets?
Keep it out of the sun.
Yes, this medication does not do well, so we want to keep it in a cool, dry place, right? Out of the sun and in the dark. Atenolol, what type of medication is this?
Beta blocker.
Yeah, this is a beta blocker. So we've talked quite a bit about beta blockers, so I feel like hopefully this is going to be a pretty quick review for you. But the cool thing about this one, we're looking at beta blockers. Most beta blockers block beta 1 and beta 2 receptors, right? Unless they're selective. So a non-selective will impact beta 1 and 2. And these block the action of epinephrine and norepinephrine, right? And they decrease the workload of the heart and oxygen demand. So they act in similar way to our nitroglycerin, right? By decreasing that oxygen demand. So a beta 1 blocker in atenolol, this is a selective medication, right? So it selectively blocks beta 1 receptor sites, right? So that's going to be important for us to remember. Contraindications are sinus bradycardia. So if the heart rate's too low, we don't administer this medication. So what assessment criteria are we looking at prior to the administration of this medication? What 2 things are going to be the most important for us to look at before we give it? Heart rate and blood pressure. And once again, same rules apply. If heart rate is below 60, are we going to give the beta blocker?
No.
No, we don't want to give this medication if our patient's heart rate is too low. We also want to be careful in patients who are experiencing pulmonary edema or acute bronchospasm, because we can see a potential risk associated with those beta receptor sites, right, and bronchoconstriction. So we're always going to be very careful with beta blockers, right? We're going to use caution in renal dysfunction and diabetes. Why am I worried about my diabetic patients?
It can cause hypoglycemia.
Yeah, this medication can interfere with our medications that are designed to lower our glucose levels. It can also mask the signs and symptoms of hypoglycemia, right? So really important. Use extreme caution with diabetes. If we want to make sure that our patients are more closely monitoring their glucose levels, and they may have to change up their medication regimen if they start this medication, right? We'll see interactions, increased absorption with atropine and other anticholinergic drugs. We'll see decreased effects with NSAIDs and increased risk of hypoglycemia with insulin and sulfonylureas. Side effects. A lot of these drugs have CNS effects, right? It can also cause depression. I've actually seen atenolol used at times, or some of our beta blockers used at times for anxiety. So this makes sense. Some of those CNS effects is sort of relaxing and chilling things out, right? So that could potentially lead to depression associated with the medication. One of the big things too that we see with this medication is erectile dysfunction, right? We talked about this and the importance of patient teaching. We don't want to abruptly stop taking this medication. And oftentimes in our male patients, this is why sometimes we'll see an abrupt stop in taking this medication. So we'll teach them that this is a potential side effect of the medication. It usually resolves. If it doesn't, call the provider. Don't just abruptly stop taking the medication, right? And we've kind of reviewed adverse reactions, right? That's why we're monitoring heart rate and blood pressure in particular. Now, warfarin. What is the classification of warfarin?
Antithrombolytic? No, anticoagulant.
Anticoagulant. Yes, this is our anticoagulant. This is our oral anticoagulant. Thank you guys for hanging with me. I know our brains are getting mushy, but we want to get through these medications. We want to review them, all right? You can watch it back later and be like, oh, I don't know why I didn't answer that question right away. That's okay. It's late. We're tired. So this is an anticoagulant, right? So indications for use of this medication in particular are prophylaxis to prevent blood clot formation, right? So what kind of assessment criteria do I need on my patient prior to administration of this medication?
PTT.
Yeah, so with this one, we're actually looking at INR, but you're on the right track, right? Remember, we want to attach the right lab value that we're looking at with the right medication. So heparin, we're going to look at PTT. Warfarin, we're looking at INR. We're making sure that that stays in range, right? So a lot of times we're checking our serum levels on our patients, even like on a weekly basis, or maybe a little bit more frequently than that, depending on how they're doing with the medication and if their serum levels are staying steady and consistent. So INR is what we're going to closely monitor. We're also going to assess our patient for signs and symptoms of what's the biggest risk factor associated with an anticoagulant?
Bleeding.
Bleeding, right? So we're going to monitor our patient closely for signs and symptoms of bleeding. And what are we going to teach our patient about their diet associated with this drug? Do you remember?
Is
Eat
it
foods rich in vitamin K.
Yeah, we have to be really careful with foods that are rich in vitamin K because vitamin K is the antidote for this medication, right? This is one of the few times in your nursing career you're going to be like, hey, avoid that kale, avoid that spinach, avoid that broccoli. It's not going to be good for you when you're taking this medication, okay? Heparin and low molecular weight heparin. These are also our anticoagulants, right? Now, there's some differences between heparin and low molecular weight heparin, but there are some similarities. So first of all, when we're giving heparin, just our standard heparin, our routes of administration, we talked about warfarin earlier, that's usually oral administration, right, for our patients. So now we're talking about heparin. Heparin is going to be subcutaneous or through the IV, right? And we're going to closely monitor which lab value with heparin again?
PTT.
PTT, right? What's our antidote for heparin?
Vitamin K.
No, this one's protamine sulfate. Very easy to mix up our antidotes and our anticoagulants, right? Because so many of the aspects of them are the same. Warfarin is our oral administration that we have our patients taking out and about in the community. Doctors are closely monitoring their serum levels. They're coming in once a week. They're getting their finger prick, checking their INR levels. And they're avoiding vitamin K because vitamin K is the antidote, right? And then we have our heparin, and heparin is that subcutaneous injection. We can take it prophylactically to prevent blood clots. That's when we give it subcutaneously, right? We do little injections in the belly. And then we can take it through the IV in a drip format that we may titrate or change based on the patient's PTT levels, right? So we're looking at that prothrombin time, and we're trying to make it take longer for the patient to clot, right? Because it's an anticoagulant, right? Now, low molecular weight heparin is used for prophylaxis, typically, right? This is a subcutaneous injection, and because it's low molecular weight, it carries a lower risk of side effects. So it doesn't significantly impact prothrombin time, but it helps to prevent blood clots. And it has the same antidote as heparin, which is what? What's our antidote for heparin?
Protamine sulfate.
Protamine sulfate, right? So let's make sure we match, go back and review. I know we're tired. You're probably tomorrow, if I asked you to say 8 o'clock in the morning, you'd be like, I know this, I got this, right? But make sure we can match our anticoagulants with their antidote, right? And sort of break out some of those differences. Now, all of our anticoagulants are going to carry the risk for bleeding. So what am I going to teach my patient about signs and symptoms of bleeding? What does that look like?
The urine or their stool.
Yeah,
Dark
and what are their
stool.
stools going to look like?
Black
Dark
tarry.
and tarry.
Right, they're not always going to see that bright, frank red blood, right? Easily bruising, petechiae, right? Those types of things. Okay. So heparin to prevent thrombosis associated with PE, MI, and stable angina, DVT, common administrations, right? This inhibits thrombin, which prevents the conversion of fibrinogen, okay? We give this IV and subcutaneously, right? So IV is for acute thrombosis. That's an existing clot. So your patient has a PE, they have a DVT, they have something going on, right? Maybe they're having an MI, and then we give it subcutaneously for prophylactic treatment. So we're trying to prevent a clot from occurring, right? Contraindications or bleeding disorders. That makes sense. We also want to use caution in any patients who have potential risk for bleeding, right? We see increased effects of heparin with other drugs that also increase the risk for bleeding, right? So we have some medications that we already know about, like our aspirin and our NSAID, other NSAIDs and our SSRIs. Some of our antibiotics can also carry a risk for bleeding. We see some anemia associated with some of these as well. And then we've got our thrombolytics, so medications that are designed to break up a clot, right? Decreased effects of heparin are seen with nitroglycerin and then protamine sulfate, which is our antidote for the medication. So if I have a patient who's bleeding and they're on heparin, I can anticipate giving them the antidote, which is protamine sulfate, right? All right, I already did that one. I already did that one. What's going on here? Why is it? Okay. Side effects are itching, chills, and injection site reaction. A lot of times we'll see a lot of bruising associated with this medication, and adverse reactions include those things that are associated with bleeding or elevated hepatic enzymes, maybe possibly a stroke associated with bleeding, right? So we don't want our patient to hemorrhage or to have thrombocytopenia with this medication. So we're trying to avoid those things from happening by closely noting signs and symptoms of bleeding. We're also going to do a lot of patient teaching with our anticoagulants. What's some patient teaching that we'll do for a patient who's taking anticoagulants on a day-to-day basis? All right, how are we going to help them to reduce their risk of bleeding?
Don't do risky physical activities.
Yeah, that's probably a good idea, right? But even simple things like changing our toothbrush to a soft bristle toothbrush or not shaving with a razor, right? But using like clippers or things like that can also help. In fact, in the hospital, a lot of times you have to prep people for catheterization and things like that, and they just use clippers for that. We don't use razors to shave our patients anymore. I actually never have, but back in the 80s, we used to. All right, so we talked a little bit about this low molecular weight heparin. This is for prophylaxis or prevention of PE, DVT, and maybe some other cardiovascular issues, right? This one is subcutaneous every 12 hours. We're giving our straight regular heparin. How often do we have to administer that medication typically?
Every 6 hours.
Every 6 hours, right? So heparin's going to be every 6 hours. Low molecular weight heparin's going to be every 12 hours. And then our warfarin is going to be a daily dose of an oral medication. So we can see, if we think about this, how long the half-life is going to be for each medication is going to increase, right? So heparin has a very short half-life, right? So if we stop the heparin, it can exit the patient's system much faster, but its routes of administration are more invasive, like subcutaneous and IV, right? Low molecular weight heparin lasts a little bit longer. Every 12 hours, it carries lower risks, right? But it's still an injection. Whereas warfarin is an oral medication that we take. It requires some finger pricks, which are a little less invasive, and frequent monitoring of lab values, right? Make sure you know your lab values that you monitor with each one of these medications. With our low molecular weight heparin, there's no lab values that we need to monitor because it doesn't usually increase PT or PTT. So prothrombin time isn't really impacted. So we don't have to do a lot of frequent lab draws with this medication. Whereas with heparin, we have to very closely monitor those values. If we're giving it through the IV, so a higher dose of heparin, we are monitoring the PTT on the patient every 6 hours, checking those levels. So warfarin, we kind of already talked about it a little bit, cute little pills here. And this works by impacting the synthesis of vitamin K, which is our clotting factors. That's why vitamin K is an antidote to this medication. So it can actually reverse the effects of the medication, right? We don't want to give this to patients who have bleeding disorders or alcoholism. And this medication is not safe in pregnancy, right? So we definitely don't want to give it to our patients who are pregnant. And we have to use caution in a number of disorders, okay? We learned about some of the nutrient drug interactions associated with warfarin. This is a very popular question on HESI, NCLEX, things like that. Which types of foods will you ask your patient to avoid, right, while taking this medication? And maybe something simple like foods rich in vitamin K, or it may be a lovely select all that apply, where you actually have to recognize the foods that are rich in vitamin K. Drugs that increase the effectiveness of warfarin are often those drugs that carry a risk for bleeding associated with them, right? And then remember, allopurinol too is one that we talked about last unit that also increases risk for bleeding. Decreased effectiveness of heparin are seen with barbiturates, laxatives, phenytoin, and oral contraceptives, right? Oral contraceptives, there's a known link between clotting and oral contraceptives, so that makes sense, right? Kind of working against each other. Side effects of heparin also can include headache and gastrointestinal distress and alopecia, right? We also want to pay close attention to some of these adverse effects, particularly the purple toe syndrome, bone fracture, chest pain is a big one too. And then life-threatening, of course, we're always watching for those signs and symptoms of bleeding. Anticoagulants are a popular test item on your future standardized testing. So please don't let these exit your brain, because knowing the lab values that are associated with them, knowing the antidotes that are associated with them, and recognizing a potential problem with any of those is going to be important. Now, for the purposes of this exam, you are not required to know the specifics of what INR should be for a patient who's taking warfarin, or the specifics of what the prothrombin time should be for a patient who's taking heparin. Right? You just need to know that those are the lab values that you're going to closely monitor. So nursing interventions with warfarin: monitor INR and platelet counts, examine the client's mouth, urine, and stools and skin for signs and symptoms of bleeding, right? We have to teach the client to talk to the dentist and their doctor and let them know, hey, I'm on an anticoagulant, or encourage them to get a medical alert bracelet, might be helpful too. Use an electric razor. Our goal is that the client's INR will be within the desired range and that they'll be free from significant side effects of the medication. We're also going to teach our patients that if they cut themselves, we can expect that they're going to bleed a lot more than usual. All right. What CAMs are concerning with anticoagulants?
Ginseng, garlic. Was it the G's?
Use code bleeds.
Are G's that cause bleeds, right? So we're looking at these CAMs: feverfew, garlic, ginger, green tea, ginkgo, and then we've got our chamomile tea and hawthorn, right? So these increase the risk for bleeding, but we also have some fun ones that interfere with anticoagulation. So they increase the risk for clotting or stop the effectiveness of the medication. So those can be our ginseng, golden seal, valerian, and these can actually decrease the effectiveness of heparin in particular. Or golden seal can. So just important for us to remember, hey, let's avoid all of these while taking our anticoagulants. What are important patient teachings related to antiplatelet medications? Do you remember our antiplatelets? What are antiplatelets?
Like Plavix or.
Yeah, clopidogrel, right? All right, so let's dive into clopidogrel a little bit. This is an antiplatelet medication. So it's used to reduce platelet aggregation. So what types of patients will be receiving this medication?
Those are like susceptible to like DVT or blood clots.
Yeah,
Maybe-
or those who have maybe had an MI or a stent placement, right? Where we're trying to avoid platelet aggregation, right? Let's dive into this one a little bit. We have aspirin as well. Remember, we talked about aspirin previously, and now we're using aspirin for its properties on COX-1, right? How it interacts with those enzymes, okay? So when looking at these two medications, we're going to closely monitor our patients for signs and symptoms of bleeding as well, right? Antiplatelet medications are going to carry similar consequences to our anticoagulants. And sometimes we'll have patients who are on both, right? So we're going to see an increased risk for bleeding. What did we see before? Oh, my patient's on warfarin and they're taking aspirin. That's going to significantly increase their risk for bleeding, right? So we're going to think about things like if my patient's having pain, right? Just standard like, oh, I twisted my ankle and I'm on an antiplatelet and maybe on an anticoagulant. Would it be a good idea for me to take ibuprofen for that pain? Probably not, right? Maybe Tylenol would be a better choice. We don't want to avoid medications that can increase our risk for bleeding. Make sure you go back and review some of these just to kind of think about what, how the drug impacts the patient and assessment criteria. Again, we're going to be monitoring our patient for signs and symptoms of bleeding. We're also going to be teaching our patients to take these medications appropriately at the right time, the right dose. What are some key points to remember about thrombolytics?
They're clot busters.
They're clot busters, which means they carry a significant risk for what?
Bleeding.
Bleeding, yeah, that's going to be one of our biggest things. So some key points to remember about this is if I have a patient who is actively bleeding, carries a significant risk for bleeding, or may, potentially have an injury that could be causing bleeding that I can't see, this may not be a safe medication for them. So what am I giving this medication for then? It's a clot buster, but what types of conditions will my patient have if they're receiving this medication?
MI or stroke.
Yeah, MI or stroke, and an ischemic stroke in particular, right? Will we ever give this medication for a hemorrhagic stroke?
No.
No, that's a big red flag. And that's also a popular question that we see sometimes on Hesse and NCLEX is, do you recognize that this medication is a strong thrombolytic? So you recognize, oh, this medication is associated with stroke. That's a good drug for the patient to get. But if it's not the right kind of stroke, then it's not going to be safe. If we give a thrombolytic to a patient who's hemorrhaging, who's having a stroke as a result of hemorrhage, what are we going to do? We're going to make it worse, right? We're not going to solve the problem or make it better. So make sure we know what type of stroke we're giving this medication for. So let's get into it a little bit. Our alteplase or TPA is our thrombolytic of choice that we're reviewing for this session. Now, there's a lot of criteria in association with the timing of this medication. It's not a medication that we can just take anytime, right, to help the patient if they're having an MI or stroke. There's usually a very narrow window of time that they can receive this medication. Sometimes we call it the golden hour, right? Or the time in which they can receive it. So not like photographs that you're taking, with your photographer, but like the narrow window of time that, you can get this medication on board and it can make a difference for the patient. So what are we going to monitor while the patient's taking this medication?
Labs and vital signs.
Yeah, labs and vital signs. We're going to closely monitor our patient also for signs and symptoms of bleeding, right? This is an acute and emergency drug. So it's not one that's going to be given, out and about in the community very often. It definitely not intravenously, and it's definitely not a medication that will, if you're working on like a med surg unit or observation unit, that you'll likely be giving. You'll more likely see this in the ER or the ICU. Okay, lots of complications associated with this drug. Most of the time, those complications are associated with bleeding, although they can impact like cardiovascular issues like hypertension and things like that. So we're going to monitor vital signs. We're going to observe for signs and symptoms of active bleeding. We also have an antidote for this medication. So this is aminocapric acid. We have an antidote. We should know what it is, right? Examine the client for active bleeding 24 hours. So we have to monitor our patient for a long time after taking this medication. And remember, if we have a patient that's taking heparin, heparin has a short half-life, right? So if we stop the patient's heparin and administer the protamine sulfate, usually we can get the bleeding stopped pretty quickly. But in a medication like this, we can't just get it stopped super quickly. And so we're going to have to make sure that we closely monitor our patient every 15 minutes for the first hours, every 30 minutes until the 8th hour, and then every hour after that. So this is a very closely monitored patient. This medication also carries a significant risk of anaphylactic reaction. So patients can be allergic to this medication. So we're not leaving our patient's bedside when we're starting this medication. We also want to avoid poking this patient as much as possible because they're going to bleed a lot. And teach the client to report side effects included lightheadedness, dizziness, palpitations, nausea, and pruritus. Now, who is your client that is contraindicated for this medication? Who's not going to get it?
Bleeders.
Bleeders and anybody who carries a risk for bleeding. So if you have a patient that's had a recent head injury, who's had a recent surgery, right? Those are all going to be red flags to you to say, this patient has a potential risk for bleeding. So if my patient's actively bleeding, they're not getting this medication. But let's say they had a stroke, they fell over and they hit their head. They're also not going to get this medication because we don't want to increase their risk for intracranial bleed, right? One of the side effects that's associated with this medication is stroke. You're like, wait, this medication is to treat stroke, but it can cause a hemorrhagic stroke, right, in our patients. So we don't want to give it to patients who carry a risk for bleeding, and that can be injury, surgery, things like that. So important for us to remember. All right, let's talk about statins a little bit. What are statins? What's this classification that we're looking at here?
Anti-lipidemia.
Right? So in layman's terms, like if I'm just your run-of-the-mill patient, what are you going to tell me I'm taking this medication for?
Cholesterol.
Yeah, I'm going to lower my cholesterol, right? In particular, my LDL, right? HDL is our high five, good cholesterol, right? What we want to see high and good and in the normal range. And our LDL, we want it low, right? We don't want those numbers to be high. So this medication is utilized to lower cholesterol. Have to think about, okay, what are some non-pharmacological interventions to lower cholesterol? Those are going to be associated with diet and exercise, right? So we're going to low trans fat diet and probably reduce some of our sugar too, right? Because our triglycerides can also impact our LDL. When we're taking this medication, there's a number of things that we need to think about. We have to monitor our patient's lipid levels and liver enzymes with this medication. We're particularly looking at LDL. And one of the ways that we can tell this medication is working is if the patient's LDL is going down, right? That's what we want to happen. We're also going to instruct the client to report promptly any muscle tenderness or weakness. This can be a sign of an adverse reaction or toxicity with the medication. So we want to catch it early if possible, right? Instruct the client to take the drug with sufficient water or with meals to alleviate gastrointestinal upset. So the patient may experience some stomach problems associated with this medication. So not a bad idea to take it with food, usually breakfast, right? We also want the client to have annual eye exams to report changes in visual acuity. We've had a few medications where this is a recommendation, so I don't want you to get it confused. Make sure you're associating this with your statins, right? In particular, we're looking at atorvastatin, but most of your statins are going to be the same. And instruct the client not to abruptly stop taking their statin drug because serious rebounds effects might occur that could lead to acute MI and possible death, right? So we're keeping those lipids at bay. We're keeping that LDL down. And if we abruptly stop the medication, we can reverse those effects and cause a pretty significant issue with our patients, okay? What are some important teachings related to antihypertensive medications and what are some different classifications?
Sorry, can I ask a quick question about the Lipitor real quick?
Yeah, sure.
Should we know the difference between when a drug causes withdrawal versus when a drug causes a rebound effect, or is it like one and the same?
No, they're kind of different, right? And it's tricky, right? But in this case, we're replacing a function within the body. And when we're replacing a function within the body that's supposed to be occurring naturally, we'll see a rebound effect associated with that. So one of the most common drugs that we'll see this with is when we start talking about hormone replacement therapy, right? Like if you're taking levothyroxine, for example, is a drug that's really common. It's replacing your T3, T4, right? It's replacing that hormone function. If you abruptly take it away, your body's going to kick into overdrive, right? Trying to make up the difference. We don't want that to occur. So with a lot of these medications, we'll see that happen where we're suppressing things from happening. And then when we take away that block, it's like the floodgates open, right? And it's causing it to occur more. Whereas withdraw, we sort of become dependent on that medication. And so it's almost as if like we'll experience things like tremors or sickness or things like that that are not associated so as much with the intention of the drug. Does that make sense?
Yes, thank
I'm
you.
hoping that makes sense. Okay.
Yeah.
So they're a little bit different, but they're kind of similar concepts, but there is a distinction there, right? So going back to my question, what are some important patient teachings related to antihypertensive medications? What are you going to teach your patient?
Take your blood pressure.
Yeah, take your blood pressure before administration of the medication. Take your blood pressure routinely, right? Make sure it's safe for you to take the medication and that it's working effectively. Sometimes we'll have patients keep logs of their blood pressure. We're also going to teach our patients about orthostatic hypotension. Remember, when we're taking antihypertensive medications, we're telling them to get up slowly, right? We're also going to teach our patients don't abruptly stop taking this medication, right? Or when you start to feel better, you don't get to stop taking the medication. These are typically lifelong medications that patients will be taking, right? Or if they're going to stop them or taper them or change the dosage, that's going to be under the direction of a provider. So don't go rogue and do your own thing. What are some different classifications of our antihypertensive medications?
Diuretics.
Diuretics are one, yeah.
Calcium channel blockers, beta
Mhm.
blockers,
Mhm.
ACE inhibitors.
Right? Lots of different kinds of antihypertensives, and they have a lot of things that are in common, a lot of things that are different, right? So hydrochlorothiazide is an example of what?
Thiazide diuretic.
Yeah, thiazide diuretic. So it's a classification of a diuretic, right? Why are we taking this medication?
Sometimes for like edema, like fluid
They're
removal.
trying to, yeah, a lot of people refer to this as like their water pill. Maybe you've heard somebody say that at some point, right? It's trying to pull fluid out of the third space back into the vascular space, activate the kidneys and get it out. So when we take diuretics, what's one of the things that we see happen with our patients as far as their urine output?
It
Increases significantly, right? So would we want our patients to take this before they go to bed? Probably not, right? You wouldn't want to wake up in the middle of the night peeing all night, right? So there's some logical things that we can think about associated with this medication and teaching, right? So let's talk about our thiazide diuretics, right? Or thiazide-like diuretics. In particular, we're talking about hydrochlorothiazide. That's our hallmark drug, but any iazide is going to kind of fall into this category, right? So this increases urine output. Is used to treat hypertension, edema, heart failure, ascites, right? Pooling of fluid in areas where we don't want it. So it's taking that fluid, pulling it back into the vascular space, activating the kidneys and flushing it out. So we pee a lot when we take these medications, right? But it also reduces blood pressure. Think about it, this makes perfect sense, right? Do we have increased blood pressure if we have fluid in the third space? Yeah. We have pressure all around the vascular space, right? When we have fluid accumulation and edema occurring. So this will reduce blood pressure. Side effects are central nervous system effects, gastrointestinal effects, and hypotension. One of the important things to remember about hydrochlorothiazide is that it does cause photosensitivity, right? So that's a big one. And then orthostatic hypotension is really important. We'll also see severe hypokalemia associated with this medication that could be a life-threatening complication. So this medication can impact potassium levels. With our diuretics, we're going to be very closely monitoring our potassium levels, right, in our patients. We have some that are potassium sparing, some that are potassium wasting, right? We have to monitor vital signs and serum electrolytes, particularly focusing on those potassium levels. We're also going to monitor our patient for signs and symptoms of hypokalemia. So heart problems, muscle cramps, monitor the client's daily weight and urine output. So a lot of times when we have cardiac patients that have a lot of fluid accumulation, we want to measure that fluid accumulation. One of the ways that we can do this is by measuring a daily weight on our patients. This is actually one of the best ways to determine fluid accumulation. So and when you guys go into the hospital, you'll see that a lot of the beds have weighing capabilities on them if you have patients who are bedridden, but we are checking a daily weight on our patients, right? We want the client to take the drug early in the morning to avoid sleep disturbance, because you don't want to pee all night. I don't want to pee all night. They don't want to pee all night. Instruct the client to slowly change positions. That's going to be true of all of our medications that impact blood pressure, right? What are some similarities and differences between furosemide and spironolactone?
Furosemide's rapid acting.
Okay. What's one of the big differences between the two medications?
Spironolactone is potassium sparing and the other one isn't. I forgot.
Yeah.
what it is.
Furosemide is going to be potassium wasting, right? What does that mean when I say a drug is potassium sparing or potassium wasting?
Isn't it when one increases sodium and one decreases sodium?
So it's actually going to be associated with potassium, but you're close. It's when furosemide is potassium wasting. So with this medication, we'll see a significant decrease in potassium levels, right? So probably not a good idea to combine furosemide and hydrochlorothiazide because they can both lower potassium levels, right? But spironolactone is potassium sparing, meaning that it doesn't necessarily impact the potassium levels. It doesn't decrease the potassium levels. So we could combine spironolactone with hydrochlorothiazide, and sometimes we do see combinations of those two medications because one will lower potassium and one won't impact it. So they can be friends, right? They can work together. So when we're talking about different types of diuretics, it's important to know what type of diuretic impacts the potassium level and how it impacts the potassium level. This is going to be important as we start to talk about potential drug-to-drug interactions. So we just talked at the very beginning of our cardiac discussion about a drug called digoxin. Does digoxin impact potassium levels?
Yes.
Yes, it can lower potassium levels, right? We also know that digoxin is prescribed to patients with heart failure. Are diuretics prescribed to patients with heart failure? Yeah, so we can see how maybe combining some of these medications can potentiate the risks associated with hypokalemia, right? So we look at digoxin and we look at furosemide and we say, wow, both of those drugs potentially lower potassium levels. I either am going to have to closely monitor my patient's potassium levels or recommend that they take a different diuretic that is potassium sparing so that they can balance each other out, right? So they don't negatively impact, right? So when we're taking medications like furosemide with digoxin, we're going to have to closely monitor potassium levels. We're going to observe our patient for signs and symptoms of hypokalemia, and then we have to make sure that we administer IV furosemide slowly. If we just push it in super fast, we can actually cause ototoxicity with our patients. A lot of times in the hospital, if I had a very low dose for IV administration of Lasix, I would dilute it in normal saline so that I could push it very slowly. So I would get a flush and flush out a little bit, draw up the rest as my Lasix, and then push it in very slowly so that we don't cause that toxicity issue. Also, furosemide is a medication that is highly protein bound. So we have to sometimes monitor our patients' albumin levels prior to administration of the medication. We're gonna know that the medication is working by seeing a reduction in fluid accumulation. So remember, one of the ways that we can tell through the mechanism of action is that we'll see fluid pulled out of the third space and kidneys are activated. So urine output should increase associated with this medication. But remember, the goal is not to increase urine output. The goal is to pull that fluid, right, out of that third space and decrease that fluid accumulation, right? So really important that we recognize, yeah, it's going to activate the kidneys, it's going to increase urine output. So we're going to see increased urine output when we give this medication, hopefully with our patients, right? But our goal is to get that fluid off of those spaces that it's not supposed to be in. We're almost done, guys. I can feel it. All right. So things that we need to do: monitor urinary output, record vital signs, and report abnormal changes, right? Observe for signs and symptoms of hyperkalemia with potassium-sparing diuretics, and administer spironolactone in the morning to avoid nocturia. Advise clients with high serum potassium levels to avoid foods high in potassium. So interestingly, if we have a patient who's taking furosemide, we might tell them, hey, eat foods that are high in potassium, right? Especially if we're combining furosemide and digoxin, right? We're gonna be like, hey, eat those potatoes, eat that banana, get all the potassium you can through your diet, right? We may even have them supplement with some potassium. But if we have a patient who's taking spironolactone, we're still monitoring potassium levels because we don't want those potassium levels to get too high as well. And so in this case, we may say, hey, if your serum potassium levels are getting a little high, you might want to lay off the potatoes. You might want to lay off the bananas. Might want to decrease the potassium levels, right? So depending on what type of diuretic our patients are taking, we have to look at what our patient teaching is going to be. It's easy to mix these up. So make sure you're assigning the correct teaching with the medication, right? And thinking about how this can apply in a setting for you. You have a patient who is consistently having low potassium levels that's taking furosemide. You might recommend to the provider switching them to a potassium sparing medication, right? So that they can still get that alleviation. Or you, on the flip side, if you have a patient who's consistently taking a medication that is, and their potassium levels are high and they're taking a potassium sparing medication, you might switch them to a potassium wasting medication, right? So things to consider. Lisinopril. What type of drug is lisinopril? What is its classification?
ACE inhibitor.
This is an ACE inhibitor. What is one of the most common and annoying symptoms associated with an ACE inhibitor?
Is it a cough?
Cough. The cough that I have right now, I'm not on an ACE inhibitor, but I feel like I am because I'm coughing like I am. So yeah, a lot of times patients will want to switch because they may get a little cough, and sometimes that'll resolve for patients, but it doesn't always. And so if that continues, they may want to switch to like a calcium channel blocker or something like that, or an ARB. So why do we give lisinopril? What is this medication for? Hypertension. Yeah, so we're trying to reduce our patient's blood pressure, right? What about our sorry, hang on. I'm getting ahead of myself here. So contraindications for this medication include hyperkalemia and pregnancy. So that kind of gives us an indication that this medication can potentially impact potassium levels as well. You guys, a lot of our cardiac medications impact potassium. It's important for us to understand if they increase or decrease potassium levels. What's our normal potassium level again?
3.5.
3.5 to 5, right? Looking at these side effects associated with this medication, you can see that cough is highlighted, right? Just think of your Professor Jensen and how she coughs the entire time she's teaching you guys, right? It's annoying, right? You wouldn't want your patient to experience that day in and day out, right? It also has central nervous system effects and good old orthostatic hypotension. You're just going to be teaching all the time your patients about this. Adverse effects can include angioedema. And then of course, with this medication, we can see hyperkalemia with potassium sparing diuretics. So if we have a patient who's on lisinopril, we're probably going to be recommending that they take furosemide and not spironolactone, right? Important things to think about. You can see how kind of all this little matrix of drugs is coming together. Who gets to hang out with who gets to be friends with who can't sit with us, right? So lisinopril is like, sorry, spironolactone, you can't sit with us, right? You're not cool enough, okay? So we also want to avoid foods that are rich in potassium, and we have to assess blood pressure prior to administration of this medication. It's an antihypertensive. Any antihypertensive, we need to know our patient's blood pressure before we administer. What about valsartan? What type of medication is valsartan?
An ARB.
An ARB, and this is often what we'll switch patients to when the ACE makes them cough. We'll switch them to an ARB, right? It's also an antihypertensive, so let's get into it a little bit. We're going to do treatment of hypertension and heart failure, right? This is a potent vasodilator, right? So it's a little bit stronger of a medication. Lisinopril is not as potent. And we have some cautionary tales associated with this. So really careful with renal and hepatic impairment. We don't want to give this if the patient has hypotension or heart failure if we can avoid it. We also want to avoid situations where the patient has low blood pressure, so hypovolemia. But look again, we want to use caution in patients who have hyperkalemia and in pregnancy or breastfeeding, right? So this is an antihypertensive. It interacts with diuretics, MAOIs, and alcohol may increase the hypotensive effects of this medication. If you have a lot of cardiac issues and hypertension, and you're taking an antihypertensive, we want to probably try to avoid alcohol. It's not your friend. ACE inhibitors and aspirin may increase hyperkalemia and renal dysfunction, and digoxin and NSAIDs may increase renal dysfunction. So combining valsartan with an ACE inhibitor, so combining an ACE and an ARB may increase the risk for hyperglycemia and problems with the kidneys, right? And that makes sense. The more drugs we take, the more potential adverse reactions we might have, right? And digoxin and NSAIDs may increase renal dysfunction. Side effects, big one with valsartan, our good old friend erectile dysfunction. Sometimes this goes away, sometimes it does not. And then our adverse reactions include orthostatic hypotension, so teaching our patients about what they're supposed to do to avoid this, and hyperkalemia, so knowing what our normal potassium level is, what do signs and symptoms of hyperkalemia look like, and how do we teach our patients to avoid hyperkalemia? By avoiding those foods that are rich in potassium, right? How do CAMs impact antihypertensive medications?
Some of them decrease blood pressure.
There's some CAMs that can naturally decrease blood pressure. A natural decrease in blood pressure could potentially be like garlic, right? We talked about garlic supplements previously, but here's some more. So hawthorn, golden seal, and parsley, who'd have thunk, right? Parsley can actually decrease blood pressure. And then licorice can increase blood pressure. So we were already supposed to avoid licorice earlier, and now we're supposed to avoid it again. So our cardiac patients that are taking cardiac meds, licorice is going to be on your list of things where we're like, hey, probably not a good idea, right? Look at that, guys. We're done. We're finished. And, you know, it wasn't like, it was 2.5 hours. Okay, close. We're almost 2.5 hours. Does anybody have any questions for me? Caroline.
Yes, when will you be uploading this? Because I'm definitely gonna have to go back through it, Professor.
So I'm hoping that the turnaround time on this will be pretty quick, but I'll be looking at the latest probably tomorrow morning, but maybe later tonight after I get myself some dinner. It'll be ready and I can get it uploaded for you guys. I'm going to try again. I said I was going to try and find those concept maps. They are available to you though in the PowerPoints. You should be able to see them. If I can't find them, I encourage you guys to create your own with any of the medications. So it might not be a bad idea with some of the cardiovascular medications. So you can highlight those important things. A little bit of gamification in your study groups never hurt anybody. So, you know, taking those ideas, cutting them out, putting up a sign and saying, okay, these are your, with your anti-infectives, these are the things that, these are the super infections associated with this drug, or these are the adverse reactions, or what does everybody have? GI distress, right? So what do they all have in common? What are they different? Don't get those confused, right? Make sure you're tying the right thing. Don't get your antidotes mixed up. It's easy to do. Students often do it. I can't tell you how many student meetings I've had where it's like, oh, you assigned the wrong antidote to the medication or whatever it was. But I'll try to get these uploaded. I know it was super long. I also know that I didn't go through every single medication on your drug list, but you know, I did my best to try and give you some tips and pointers of what you need to review. But as you go through and review, if you're struggling with a particular medication, not a bad idea to look at those PowerPoints and see what's highlighted, bolded, underlined, right? I'm gonna see if I can get access to a Kahoot for you guys again. So I might have a couple already. I'm gonna look and see. So just be watching the announcements and see what's uploaded for you in the next day or so, okay?
Perfect. That's what I was gonna ask next, is if you
Yeah.
had just the Kahoot, you know?
I think I for sure have one for weeks 8 and 9. I don't know if I have one for your anti-infectives. So I'm gonna try and see if I can find one, but you'll have one. We have a couple, I think, for cardiac drugs. Okay,
Thank you.
you're welcome. You guys have a wonderful evening. Go get some dinner and get some good
Yeah.
sleep. All right, bye guys.
Thank you.